Uh, the thing is, this will be more of an interactive kind of session. So I'm going to ask you questions and you need to answer them. And accordingly, I'll do discussion on them. What is the final diagnosis on these cases?
म्यूट मुझे
Okay.
भाई नहीं पड़ेगा.
Uh, so this is a so I'll start with these. These are the basic cases, and most likely from exam point of view, if you need to know the classical morphology. So pay attention to the history also, and then you look at the morphology. So this is a 20-year male with I just want to know how many students are there. Puneet, total 32 participants are there.
The current 32 total.
Okay, 32. So how they are going to answer these questions? So everybody will be unmute or what kind of a thing we are going?
Yes, sir. They can unmute themselves and answer, or they can raise their hands and you can pick them up, sir.
Okay, fine. Done. So this is a 20-year male with nephrotic syndrome. So what you can see here is you can see three glomuli. This is the PS stain. Okay. Just look at these two glomuli. This glomulus looks fine. So these two glomuli are showing something, some pathology. So this is a higher magnification of the glomulus, which is showing a lesion here. Immunofluorescence show IgM, which is like this. The rest of the immunoglobulins and complement were negative. This is a electron microscopy. So I've already written what it is showing, but you need to concentrate. There are hardly any food processes. So there is a food process effacement which is there. So what is the likely diagnosis in this? First, minimal change disease, primary FSGS, secondary FSGS, or membranous globulopathy. So they are going to answer that. So you can raise your hand or okay. Okay, majority of you they have diagnosed this as primary FSGS, which is absolutely correct. See the thing. Why I showed you electron microscopy is the reason for that is there is diffuse photocytic foot process effacement. So when there is the diffuse photocytic foot process effacement, it is primary, and then there is a segmental sclerosis lesion in the light microscopy. Uh, Anybody can tell me what is IgM? There is some IgM staining which is seen. I'll show you that. If anyone wants to answer this, so there is a IgM staining. So this is, I'll tell you, this is a non-specific IgM trapping which you see. Okay. So non-specific IgM trapping can be seen in areas with segmental sclerosis. So IgM and C3 non-specific trapping can be seen in FSGS lesions. But yes, important thing is there is a significant role of electron microscopy in differentiating primary and secondary FSGS. The moment there is diffuse photocytic effacement and segmental sclerosis lesion in light microscopy, it is consistent with primary FSGS. Now we come to the second case, 35-year male with nephrotic syndrome. Look at this morphology. This is a HND stain. You can see here. This is a PS stain. This is immunofluorescence IgG. You need to look at the pattern of staining. So do you think it is granular or it is linear? Just be careful about that. Because if it is granular, that suggests immune complex mediated disease. If it is linear, that suggests some anti-GPM disease, non-immune complex mediated disease. IgA, IgM, C3, C1q. They are all negative. So this is the electron microscopy. So this, I must tell you that this is the globular basal membrane, and this side is the podocyte, cytoplasm, and this side is the endothelial side. So you can see endothelial cell here. These are the endothelial fenestrations, and you are seeing some structures here, some things here, which are towards the This is a podocyte cytoplasm. So beneath the podocyte cytoplasm, you are seeing some structures. Whether you want to label them as subendothelial, whether you want to label as intermembranous, or you want to label them as subepithelial. So what is the likely diagnosis? Membranous globulopathy, MPGN, FSGS, proliferative lupus nephritis. So membranous globulopathy, MPGN, FSGS, membranous nephropathy. Okay, okay. So good. So this is membranous globulopathy or membranous nephropathy because we are not seeing. Uh, there are immune deposits which are definitely the IgG staining is there, and the other thing is these are the subepithelial deposits, and these are very uniformly placed, dark colored electron dense subepithelial deposits. As I've told you, this is a podocyte cytoplasm. So beneath that, you are seeing these subepithelial deposits. Okay, and this is the endothelial side. Had it been lupus nephritis, you would have found some subendothelial deposits also. Okay, had it been MPGN, there should have been a subendothelial deposit. The other thing is, if you see the immunofluorescence pattern also, whenever there is a lupus nephritis, it is a full house IF pattern in majority of the cases. So you'll find C1q also, which is not there. So that rules out possibility that it is unlikely to be lupus. The second thing is MPGN will show IgG, C3, sometimes C1q also, so which is not seen. And this is a classical pattern of primary idiopathic membranous where there will be IgG 3 plus and C3, and rest of the immunoglobulins and complement will be negative. Even in a primary idiopathic membranous, the C3 can be trace or can be negative. It is very unlikely, only in 10 to 15% cases, you are going to see 3 plus C3 in a primary idiopathic membranous. In majority of the primary idiopathic membranous, C3 is traced to minimal and it is dominantly IgG staining what you see. So good, it is membranous globulopathy. So we come to the next case, 25-year female with active urinary sediments and proteinuria. So this is the morphology. You can see a PS stain here. You can see something here. You can see these globuli. They have got a lobular accentuation. So these globuli have lobular accentuation. There's a high magnification which shows there is something, some massive kind of deposit which is there. And then there is something here. And this is a Mason's trichome stain. So Mason's trichome stain, it highlights deposits as fusionophilic deposits. So you can see the red color things, all these are massive deposits which are seen. The immunofluorescence pattern. So what is the likely diagnosis? Is it membranous, IgA nephropathy, proliferative lupus nephritis, or C3 globulopathy? So I can't see. So what is the diagnosis you have given? Okay, chat shows that majority have given this as lupus, class 4 with crescents, CCC, endocoupling hypercellularity with crescent in one kilometers, lupus nephritis, yes. So it is a proliferative lupus nephritis because you are seeing a full house IF pattern and there are these massive deposits. When you see these kind of massive immune deposits, there are only three possibilities you have to consider. First is lupus nephritis, second is MPGN, and the third is if it is a cryoglobulinemia. Since you are seeing very strong C1q and C1q deposits, so you favor lupus nephritis. But yes, if you see this kind of a morphology and a full house IF pattern, your first diagnosis should be lupus nephritis only. Okay. So we come to the next case. So here, tell me what is the pattern of injury. So I have already written. So you can see the mesangium, which is expanded. There is mesangial hypercellularity. Why, when I say mesangial hypercellularity, there are four or more than four nuclei. So you can see one, two, three, four, five nuclei here. So there is mesangial hypercellularity, four or more than four nuclei. So one, two, three, four nuclei in this mesangial area also. So what are the differential diagnoses when you see a mesangial proliferative globular morphology? IgA nephropathy, resolving PIGN, class 2 lupus nephritis, or all of the above? So answer is D, all of the above. Absolutely correct. So mesangial proliferative morphology you see in all of these cases. So how will you differentiate? If you find IgA deposits, dominant IgA deposit, it is IgA nephropathy. If you find C3 deposits, it is a post-infectious glomerular nephritis resolving, or it may be C3 glomulopathy also. If you find full house IF pattern or with mesangial deposits and with along with C1q, it is class 2 lupus nephritis. So this morphology can be seen in all these three entities. So good. So we come to the next case now. So what is the pattern of globular injury in this case? Just look at the pattern of globular injury and see this is C3, which is C. So what is a, sorry, so I have already said that. But when you find this kind of a morphology is called as exudative globular morphology. When you see a lot of neutrophils in the globular capillary loops. So this kind of exudative globular morphology is seen in infection-related glomerular nephritis. So there, some renal pathologists still prefer terminology of post-infectious glomerular nephritis, but some say that it is not post-infection you are finding that. Sometimes during active infection also you can find this kind of a morphology. So they say it is better to label them as infection-related glomerular nephritis rather than labeling them as post-infectious glomerular nephritis. But yes, if you find exudative glomerular morphology with C3 deposits, there are only two possibilities you can consider. Either it is a post-infectious glomerular nephritis, active kind of a thing, active phase, or you can think of C3 glomulopathy. For a C3 glomulopathy, there is no MPGN pattern, and that is the reason you are favoring a post-infectious glomerular nephritis. So it is an infection-related GN. So I come to the next case, 25-year female with RPGN. So this is the morphology you can see. So what is the likely diagnosis? MPGN, post-immune crysantic, anti-GPM crysantic, lupus nephritis. Anti-GBM, okay. Crysantic GN, that is fine. Good pastures. Okay, okay. So the thing is, there is no doubt that this is anti-GBM glomerular nephritis because there are crescents which are there, and there is IgG. If you look at the pattern of staining of IgG, it is a very linear pattern of staining. I've shown you the membranous case in which the staining was granular. So here you are finding a linear staining. So linear pattern of staining means it is a non-immune complex mediated disease. So anybody can show you this pattern and ask what kind of staining it is. So it is a linear pattern of staining. So it is consistent with the, and then there are crescents. And the interesting part is all the crescents are of the same age. They are all cellular crescents. Okay. So all crescents of the same age with this kind linear pattern of staining is more consistent with the anti-GBM disease. On the other hand, same morphology, and if you don't find linear staining and there are no other immune complexes, only maybe C3 minimal is there, you label that as possible presenting globular nephritis. Why not MPGN? Because MPGN should show granular staining, and then MPGN should show other. There will be C3 also. There will be minimal C1q also, which can be seen. Lupus nephritis, it is not lupus because it is not showing any full house immunofluorescence pattern. So lupus, if it is a proliferative lupus, the immunofluorescence pattern will be full house majority of the times. It is not possible that morphology is like a proliferative lupus and immunofluorescence is negative, or it is showing only IgG. So it will show a full house. And the other thing is the pattern of staining also of IgG, which I have told you. Linear pattern of staining more consistent with a non-immune complex mediated disease. So it is an anti-GPM presenting. So look at this morphology. Tell me what are your differential diagnosis? This is a HND stain. This is a silver stain. This is albumin IF. Again albumin IF. So this is the pattern. So you can see these kind of lesions. So KW lesions, classical. Yes. Always remember whenever you see abs- absolutely correct. I'm impressed from Dr. Arun Dua. He has given all the differentials. Yes. So it is nodular glomerulonephritis. Uh, the differentials, what Dr. Arun has given, absolutely correct. Diabetes, amyloid, MIDD, smoker. So by smoker, when he says that means a patient who is a chronic smoker, he is chronic hypertensive, elderly patient can have these kind of nodular glomerulosclerosis lesion. It is labeled as idiopathic nodular glomerulosclerosis. Okay, but the thing is, idiopathic nodular glomerulosclerosis is a diagnosis of exclusion. You need to exclude diabetes, you need to exclude amyloid, you need to exclude MIDD. So when I say, when you look at the morphology also, so I'll show you the morphology of these nodules. So these are varying size nodules. You can see a big nodule like this, a nodule of a slightly smaller nodule like this, and then a smaller nodule like this, and a vague nodule like this. So varying size, asymmetrical nodules, that is more commonly seen in diabetes. But always remember, whenever there is a nodular glomerulosclerosis lesion, your first three diagnoses should be diabetes, diabetes, and diabetes. And uh, if had it been like no albumin staining, kappa showing 3 plus staining, linear staining, and lambda being negative, this is a light chain deposition disease or MIDD. Okay. On the other hand, if you find so this is not like amyloid. Reason for that is, if it was amyloid, it will be silver negative. So this is a silver positive mesangium. That means it is the normal mesangial matrix. There is nothing exogenous. No exogenous material is deposited in the mesangium. So the normal mesangium is always PS positive. It is silver positive. When you find PS negative, silver negative nodular mesangial area, then you think of amyloid, and then you can do congruent stain and all that stuff. So albumin will not show this pattern of staining in amyloid. So you are seeing 3 plus staining of albumin along the tubular basement membrane, and also some staining in the glomeruli. So it is diabetic nephropathy. Okay, tell me about this glomerulus. What do you think this is? This is a 70-year male with nephrotic syndrome, and you can see this is a PS stain. This is also a PS stain. So just compare this color. Normal PS color is along the tubular basement membrane. You can see a PS positive thing. Okay, you can also see a PS positive tubular basement membrane. And just tell me, what are these structures? This structure and this structure. Do you think it is tubule? So tubule looks like this. It has got nuclei and all that stuff. Now it becomes easier. Yes, the diagnosis is amyloid. So what I was trying to show you, vessel wall deposits. Absolutely correct, Dr. Anand Chan. And Dr. Anand Jain is given this diagnosis. Absolutely correct. And he's the first one to diagnose it. Good. So there are vessel wall deposits which are there. And you can see these, and there is congophilia. Congruent stain shows this congophilia. And this is what I was trying to show is this is a PS positive tubular basement membrane, and this deposit is not PS positive. It is not of the same color. It is like slightly PS positive or weakly PS positive or PS negative. So when you find a PS negative, anything around the vessel which is PS negative, silver negative, think of amyloid. Okay. History of NSAID with rise in serum creatinine. So look at these structures. So even at low magnification, they were very dilated. And always remember, tubules normally should be arranged in a back-to-back manner. So there is some spacing in the tubules. So this is a high magnification. You can see this tubule here, tubule here. In between there is something. In between you can see this, these things. So what is your diagnosis? Is it ATN? Is it acute interstitial nephritis? Is it acute tubular interstitial nephritis, or is it cast nephropathy? Very good. Dr. Nikita, uh, Dr. Vivek, Dr. Anand. They have diagnosed with Dr. Radhika, Dr. Anish Pal. Okay, so all of you, you have diagnosed it correctly. It is acute tubular interstitial nephritis. It is not ATM because there is interstitial inflammation which can be seen here. So you can see that you can see these are the tubules, they are separated, so there is interstitial expansion. Now if you go to this magnification, you see infiltrate in these tubules. Since there is acute tubular injury, along with acute tubular injury there is interstitial inflammation, so it becomes acute tubular interstitial nephritis. Had it been the tubules absolutely fine, there is interstitial inflammation, that you label it as acute interstitial nephritis. And if there is no interstitial inflammation, only ATN, you label it as acute tubular injury or acute tubular necrosis. So in this case, both the components are there. There is ATN as well as there is interstitial inflammation. There are also few scattered these orange color cells. These are eosinophils. So it was a drug-induced acute tubular interstitial nephritis. There is history of NSAID intake also. Why it is not cast nephropathy? Because you are not seeing those kind of casts in the tubular tubules. Okay. So I'll show you. So this is a different case. So what it is showing is these are cast. Okay, just compare this color again, PS positive, magenta color, and these casts are PS negative. Okay, and then there is some reaction of inflammatory cells and the tubular epithelial cell to the cast material. You can see some fragments also. So fractured, and this can be better highlighted when you do kappa lambda. Kappa is negative and lambda is showing these fractures. You can see the fractures between the cast material. So this is cast nephropathy. So it is possible that in the exam they will show you one cast and they will show kappa lambda restriction. Mostly in cast nephropathy there will be kappa restriction in majority of the cases, and but in some few percentage of cases there could be lambda restriction also. So you have to remember only one light chain should be present, which should be 3 plus, and the other light chain should be absolutely negative. Then only you label it as cast nephropathy. Then only you say that there is light chain restriction. So I'm not trying to show you cases like MGRS and all that. So it will be a very basic kind of things which in exams they are going to ask you. So either membranous, FSGS, antigen pattern, uh, proliferative lupus, anti-GBM, crescents, and all that. So amyloid, diabetic nephropathy, these are the common things. So we come to transplant cases. So there are three cases only. So tell me, this is a transplant biopsy. And what you're seeing here is interstitial inflammation. These are the tubules. This is a PS stain, a PS stain again. So these all are lymphocytes which are infiltrating the tubules. So what is the diagnosis? Is it ATN, AMR, acute cellular rejection, or CNA toxicity? Very good. ACR1B, borderline cellular rejection. T3, okay, T3I3, very good. Yes, because there is severe tubulitis and there is severe interstitial inflammation. Absolutely. So when there is severe tubulitis, so it is not T1, it is like T3 because there is moderate to severe tubulitis. I'll show you why I'm labeling this as T3. So it is not from the exam point of view, whether you label it as T1 or T3. The important thing is you should label this as acute cellular rejection and not as ATN or anything else. So if you look at this tubule, just count the number of lymphocytes here. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. At least 13 lymphocytes in this single tubule. So more than 10 lymphocytes means it is a severe tubulitis. So there are few tubules which are showing only 3 lymphocytes, so mild tubulitis. This is tubule which is showing 1, 2, 3, 4, 5. So there is moderate tubulitis. So when you find severe tubulitis with whatever interstitial inflammation you have, it should be more than 25% minimum interstitial inflammation. You can label this as ACR1B. So it is acute cellular rejection, 1B. What do you think this is? And what are these? The, which are full of RBCs. Again, another image. So, what are the likely possibility? Is it ATN, CNI toxicity, acute cellular rejection BAMF type 1A, acute cellular rejection BAMF type 2A? Okay, very good. V2, V2, absolutely. So yes, the congested thing which I was asking, what is it? It is a PTC. Absolutely correct. So good, Dr. Prateek, Dr. Arun Dua, Dr. Nikita, Dr. Sanket, Dr. Anand, Dr. Vivek Goel. So, so this is a V2 lesion, vascular rejection, which is there. C4D was negative, but you have to remember that if C4D is positive, then it is possible that this, and if there is no tubulitis, no interstitial inflammation, and there is only isolated vascular rejection, then we have to consider possibility of AMR also. But C4D should be positive. There has to be uh, other evidence of AMR. So this was a PTC which was congested with RBCs. So whenever there is a vascular rejection, you can get interstitial hemorrhage. You can see these RBCs in the interstitium. You can get congested PTCs. You can get congested glomuli because there is a vascular rejection which is going on. So ABM compatible transplant. This is the last case, POD1 with rising serum creatinine. This is a PS chain. This was a HND chain. This is a PS chain. And this is Mason's trichome. So what do you think the diagnosis is? Transplant globulopathy, thrombotic microangiopathy, or transplant globulitis? TMA, absolutely correct. I feel you all are ready for at least renal pathology exam. I'm sure about that. So there is thrombotic microangiopathy, which is affecting all the globuli. You have to remember whenever there is a diffuse TMA. Yes, Dr. Mohit said it is a hyperacute rejection. So the thing is, I'll tell you a history about this case. So whenever we find TMA so early post-transplant, and that too in a incompatible transplant, the first suspicion is that this is possibly a AMR. Okay, but in this case, this was unusual in a way. This was a CNI-induced TMA, and it was quite significant TMA. The interesting part was why it was not like AMR, because there was no neutrophilic glomerulitis, there was no PTC capillaritis, and it is possible that in a ABO-compatible transplant, a hyper acute antibody-mediated rejection can present as only thrombotic microangiopathy. But in this case, there was only TMA. C4D was negative. There was no glomerulitis. This was a CNI-induced TMA. As the CNI was withdrawn, the TMA was better. So this was a CNI-induced TMA. But yes, it is very difficult to differentiate that. On one or two images, you can't say whether this TMA is because of AMR or because. But along with this TMA, if you get a C4D positivity, in a ABO compatible transplant, that early post transplant, if C4D positivity is there, that has that is possibly pathological. But yes, after maybe 2 weeks post transplant ABO compatible, C4D could be result of accommodation. But you have to remember that TMA could be due to three, four common things in transplant setting. First is ABMR, second is CNI, third is recurrent or de novo HUS/TTP. Fourth is if this patient had some malignant hypertension, accelerated hypertension. Early post transplant, when you see TMA, first three causes AMR, CNI, and recurrent or de novo HUS/TTP. These are the three things you need to keep in mind. So I don't think more than this. Uh, I have already shown you in my lectures how C4D positivity looks like, and you are aware about that. So I just wanted that if if you have any queries, or if you want that some additional cases need to be shown, or you want some one or two more pathologies, or maybe few more pathologies you need to see, please do let me know. If there are any queries, I'm ready to address them. So this was my last case. So this is thrombotic microangiopathy. And what you are seeing here are these are fibrin threads. So this is a Mason trichome stain which are showing fibrin threads. Okay, so if you have any doubts or queries, please. No queries? Now, I must tell you that we hardly come across cases of acute antibody-mediated rejection in a conventional transplant. We get to see acute AMR mostly in ABO compatible setting. So we see, and that too in a ABO compatible setting, you see ABMR that happens mostly in the first 2 weeks post transplant. Sir, amyloid is silver negative, yes. PS negative, yes. Amyloid is, Dr. Vivek, it is silver negative and it is PS negative. Uh, there could be occasional cases which could be positive, but I must tell you, 99% it is amyloid, always remember, is PS negative and silver negative. So in the chat box also you can ask any questions, if any queries if you have. So I'll be happy to answer them. And if you want to see any more cases, because obviously, uh, but I think this is a basic pattern of injuries you need to know: segmental sclerosis, mesangial proliferative, MPGen pattern, uh, membranous. So the thing is, Dr. Anand, identifying special stains like von Cosa, oxalate, that will be too much, because yes, oxalate. If you find this kind of a refractile kind of deposits in the tubules, you know that is oxalate. But someone has to polarize those deposits to say that these are oxalate crystals. So nobody is going to ask you in the exam identify special stains like von Cosa or oxalate stain. So there is no special stain for oxalate, but yes, von Cosa is a good stain for calcium. But in the, for nephropathology exam, nobody will ask. This is von Cosa stain is mostly asked in histopathology exams. So kindly explain light microscopic image of TMA. Okay, so I'll show you that. So light microscopy image of TMA. So I'll go to the same case. So what you can see here is just compare. This is HND stain. This is the normal glomerulus. Just compare this glomerulus with this glomerulus, and you can see bright colored cells. These are RBCs. So this glomerulus is congested. It is bigger than this glomerulus. Okay. Why it is bigger? Because there is mesangiolisis. There is disruption of the mesangium. Mesangium is like a supporting medium. So when there is disruption of the mesangium, which occurs in thrombotic microangiopathy, there is no supporting media which is going to support the glomerular capillaries. So glomerular capillaries, they get dilated and they become very congested, and that is a manifestation of acute thrombotic microangiopathy. And some of the glomerular capillaries are showing these thrombi, fibrin thrombi. This is These are just thrombi which are seen in the PST. Okay, so they look like hyaline thrombi. They look like not exactly wire loop, but these kind of things you can also see in cryoglobulinemia. They look like hyaline thrombi and all that. But the appearance of these thrombi, when you see in the Mason's trichome, they will show fibrin threads. Okay, so the moment you see a glomerulus which is showing fibrin thrombi within the glomerular capillary loops, and the glomeruli appear very congested, and there is no supporting mesangium, you think of thrombotic microangiopathy. So there could be three morphological spectrum of thrombotic microangiopathy. What I've shown you is an acute thrombotic microangiopathy where there is mesangiolisis, there are fibrin threads. Then there could be subacute thrombotic microangiopathy, which will affect the vasculature. I didn't show you any vasculature. Reason being, in your exam, if they want to show you, they will show a glomerulus. They will not show a vessel with a TMA. That is a very hi-fi kind of a thing. Okay, TMA comes, vascular TMA come for PDCC renal pathology exams. It will not come for your nephrology exams. But for nephrology exams, you should know that when a glomerulus looks very congested, when a glomerulus capillary loops are full of some material, think of thrombotic microangiopathy. Look at this glomerulus, you can hardly see any patent capillary loops. They're full of something. So all these are either hyaline thrombi or fibrin. Okay. Difference between fibrin and hyaline thrombi. Very good. So the thing is, always remember whenever there is a hyaline thrombi, immunofluorescence will help you in categorizing those hyaline thrombi. For example, in lupus nephritis, we say wire loops or hyaline thrombi. But those wire loops or hyaline thrombi which you see in lupus, they are positive for immunoglobulins. They will be positive for IgG, they will be positive with C3, C1q, all that. But fibrin will not be positive for these immunoglobulins and complement. Fibrin comes positive, fibrin will take up only fibrinogen stain. Okay, that is the difference. The other thing is, whenever you find only hyaline, whenever you see hyaline thrombi, there will be other things also which you need to look at in the glomerular morphology. For example, if it is a cryoglobulinemia, so cryoglobulinemia will show hyaline thrombi, but the globulinemia will have a amphigen pattern. There will be membrane thickening, duplication, there will be endocapillary proliferation. But in TMA, fibrin uh, accumulation in a case of TMA, you are not going to see any endocapillary proliferation. You are not going to see any crescents, and immunofluorescence will be negative. Okay, so that is how you can differentiate. Okay, so this is Dr. Anand. You are asking very difficult questions which will not come in your exams. How to identify hyalinosis versus sclerosis versus fibrosis? So I must tell you, uh, it is so I can take some maybe 10 minutes class to differentiate hyalinosis with sclerosis with fibrosis, but I must tell you this is not going to come in your exam. Don't worry about this. Always remember. Okay, I'll show you one case. I'll show you that case in which there was, just a moment. I'll show you diabetic case. So in diabetic, no, diabetes I'm showing nodular glomerulonephritis. Okay, just a moment, just a moment. I'll see if I can show you some. So you see this glomerulus is, just compare, this glomerulus is showing the segmental sclerosis here. You can see the capillary loops which are empty, okay, empty looking, and suddenly in this area the capillary loops, they are no longer patent, okay, and they have lost their patency, and there is some sclerosis, and it is like the purple magenta color PS staining is showing some positivity also. So it is sclerosis will be PS positive. Hyalinosis, on the other hand, it has got a glassy kind of architecture. So it can be weakly PS positive. It is never darkly PS positive. So when I say darkly PS positive means, look at this tubular basement membrane which is ischemically wrinkled. The color of this magenta color of this is the true color magenta color, which means whenever we say anything is PS positive, it should show this kind of a magenta color. And just compare this color which is there in this globally sclerosed glomerulus with glassy material. So this is not magenta color. This is like PS negative, or very weakly PS positive thing. And you see this kind of a glassy material when you see these are all plasma proteins. Hyalinosis, when we say it, it is all plasma proteins, and they will not be PS positive. They will be PS negative, or they will show a very weak PS stain. When we say sclerosis, when we say fibrosis, so this happens in a glomerulus. Fibrosis will be in the interstitium. You will find fibrosis when you do Mason's trichome stain. The other difference is when you do a Mason's trichome stain, the fibrosis or sclerosis will take up the green color or blue color, whatever counter stain you are using. But when you do a Mason trichome stain in a hyalinosis area, it may show a red color. It may show some reddishness. That reddishness is not because of deposits. The reddishness is because there is non-specific proteins, plasma proteins, which get deposited and which will stain with Mason's trichome stain. It is a difficult thing. So nobody is going to ask you fibrosis, sclerosis, and hyalinosis. Okay, but remember, when there is extensive hyalinosis, it is mostly seen with diabetes and hypertension. So silver and Mason stain negative for hyalinosis, blue for sclerosis. Okay, absolutely. How to identify hyalinosis? Okay. So if there are, okay, so if there are no further queries, so Mr. Puneet, so if there are no further queries, I'll stop the presentation. And if you need any further, if you want to see more additional cases, I think this will be good enough for your exam, from your exam point of view. Uh, but yes, if you want anything more, please do let me know. And wish you all the very best for your exams. Thank you.